Hi and welcome to the Health Chat. I'm your host, Andrew Whitfield-Cook. Today we're talking with Carolyn Ledowsky, a naturopath who's dedicated her whole career to helping patients with MTHFR, metabolism issues, and everything that goes with that. Today we're discussing a controversial subject of unmetabolized folic acid and how pregnancy or fertility can be affected by that. Welcome to the Health Chat, Carolyn. How are you going?
I'm well, Andrew. Thanks so much for having me. Excited to talk about this today.
Yeah, well, you're going to be giving me a bit of a brain explosion today, I know. My brain might cave in. So firstly, though, I hear that you've finished an honours thesis. Is that right? Tell us more.
That's correct, yes. Well, I've just spent the last 2 years doing that with Endeavour, which has been probably one of the hardest things I've ever had to do, because to take your practitioner hat off and put your researcher hat on is actually screamingly hard, because you know truths through clinic, but you can't know those truths in research until the research says that's a truth. And that's so difficult. But I had the most amazing supervisors. I had Amy Steele and Janet Schloss, who are just masters. They're just amazing women. And I'm so grateful and so thankful that they, were there to help me through it. But given that it's now done, it's like, oh, it's so exciting to actually see how you evolve and allow the research to sort of show you things.
That's the point, isn't it? To let the research speak and let it be.
Yeah.
Was that very hard emotionally? Like was it confronting?
Hard.
Yeah.
Yes. And I was so, in the beginning, I'd say, yes, but Amy, Janet, that's just not right. And they go, yes, I know, but you have to let the research show you. And so they took me kicking and screaming, and it really wasn't until that second year that I thought, I have to do this their way. Like, I can't fight this. You've just got to go through the process. But it is actually, now I guess we see the result. I'm so happy that we see the result that we got, because it is life-changing in terms of what it says is, okay, this is a really relevant research topic and we need to do more.
Okay, well, tell us more about this research topic, because it's fascinating to me. And I'm going to put my hand up as one of the dunces in the class. I'm old school and I have so much to learn myself. So this will be an educational experience for me, not just for everybody else out there. So let's dive into it. Tell us more about actually what you covered.
All right. So I'm going to share my screen. So for those of you that are looking at the screen, it'll help you along. And for those of you that are just listening on the podcast, I'll see if I can explain it as much as I possibly can.
Yeah. And forgive me, sorry, Carolyn, so those of you who are listening, obviously you won't be able to see what we're seeing. So please go to the Auburn Health site and you can catch up there on the Health Chat.
Yeah, but hopefully they don't have to. But, if you're looking at a pathway, then maybe it helps you to visualize this a little bit better. So basically what we had a look at was Aussie practitioners who are working in the space of infertility and regularly test for MTHFR. What forms of folate and what dose of folate do they use, and what's the outcome of fertility? So that's essentially what we looked at, just to document, and case series obviously are not a high level of evidence, but they actually give us a really in-depth analysis of a particular topic so that we can say, okay, well, research is, we need to probably research this a little bit more. All right. So the research is important because there are 70 million people worldwide that are affected by infertility. That's a huge amount of people, and it's rising. It's not going down. It's getting bigger. And so what we know, we did literature reviews, we assessed MTHFR, and research definitely tells us that genetics is a factor. And one of probably the most widely studied gene in the way of infertility is the MTHFR gene, because it controls the level of folate that we need for DNA synthesis. And so for both men and women, it can affect infertility. But we see results that are probably not conclusive. I mean, there's tens of hundreds of research studies, and some will categorically say, yep, MTHFR polymorphisms are associated with female egg issues, male sperm issues, oligozoospermia particularly. We have problems with egg and the quality of the eggs. Yet some studies will say, well, it's inconclusive, we're not quite sure. But I think one of the major factors for that is a lot of the studies come out of countries where they're vegan and vegetarians, which affects the level of folate uptake. Because if you don't have enough B12, then you can't use the folate. We also, a lot of the studies don't actually test for folic acid in food. So we're probably not getting a really good analysis of, okay, what folates are there in totality? What's the level of B12 to help that uptake? So I think we're getting inconsistent results.
You said sorry, Carolyn, you said folic acid in food. You're talking about folate in food, correct?
I'm talking about supplemental folic acid. So none of the studies actually say, well, okay, we're in a fortified country. What's the level of intake that we think people might be getting from a fortified folic acid food?
Right.
And the guesstimate in some research is it could be over 1,000 micrograms, which is a heck of a lot, when public health policy originally said we expect 140 micrograms. So because there's so many more foods, originally it was only bread flour that was fortified with folic acid. Now it's breakfast cereals, pretty well anything in a packet. It's, protein powders. It's everything that you get in the supermarket says the word folate and it's got folic acid in it.
Oh, so it's actually mislabeling.
Well, no, the general consensus is folate is folic acid. And this is also one of the biggest issues we have in the research studies, because scientists even use those words interchangeably, that folate is folic acid. So it's not until you delve into the studies and you look at, well, what are they actually testing, that a lot of the time they're actually testing folic acid. And a classic example is there was a research study that came out a couple of years ago that says high levels of folate in third trimester of pregnancy predisposed to autism, but they were testing folic acid because natural folates don't build up. They cannot build up. Only folic acid can build up.
So let's go further into this, because this is like one of the topics, and it's such a controversial issue. I mean, you can just see by the passion in your face. I mean, it teaches us that we need to not trust marketing words on packets. And delve into ingredients and fortifications in foods and really take a responsibility to what we eat.
Yes. And the reason is that folic acid is cheap and it's reasonably stable in food, so it's easy to put it in. Whereas folates that come naturally, like folinic and methyl, up until today, there's a few studies that show it can be fairly stable, but generally it costs more, it's less stable, so they only use folic acid in foods as we know it right now, in supplemental foods.
Right.
But the problem is, as I said, we're having way more than was ever intended. And I don't think anyone's really evaluating what's the implication of that.
This is a huge issue.
It is big, and I think it's probably the biggest single thing that I want to go on and research, because I think it's critically important to our understanding of what is happening on an everyday basis with people and their folate. And I don't think it just affects fertility. I think it's a huge question mark that I have around anxiety, depression, mood, aggression, everything else. I think if it's not inconceivable to think that if we are being affected fertility-wise, then why isn't our immune system also being affected? Why isn't our mental health being affected? Why isn't our detox pathways being affected? I actually think this has ramifications across every health space.
Just one question regarding that, the rise in infertility. We've also got, our burgeoning waistlines to, as a major factor there. So we have to put this in the place of this is one factor, but it's an important
Absolutely.
factor, but it's not
but you think also about EMFs and having access to, Wi-Fi all the time, and men putting their mobile phones in their pockets, and, kids having laptops on their genitals, basically sitting on the lounge. And, there's so many
even the heat, even the heat.
Exactly.
They've actually done research years ago about this. Yeah.
Yeah. And unfortunately, male sperm are so susceptible to any adverse toxicity. So it is most affected, probably more so than the female egg, to all sorts of toxicity. And when you think that we have so many xenoestrogens in our environment, we're essentially estrogenizing men. But guess what? What gets rid of estrogen? Methyls. Where do you get methyls from? Folate. And so this is the conversation. It's not just a linear, it's a multiple, flow-on effect.
Let's go further into the dosing issues, Carolyn, because this is really interesting. Are there any restrictions in Australia with regards to dosing issues?
You are only allowed to put 500 micrograms in a prenatal of methylfolate. If you have a pharmaceutical product, say Elevate, you are allowed to put 800 micrograms.
So that's an over-the-counter one, yeah?
Yes. Yeah. And so, unfortunately, up until now, we are not allowed to put more than 500 micrograms. But you can use additional folate. And as you can see, you'll see that's what these practitioners did. So let's continue the conversation and talk about, first of all, for those practitioners that don't understand what exactly a polymorphism is, for every gene in our body, we have a set DNA sequence that we expect to see. And we call that the wild type. The wild type is what we expect to see. If you see a change in a DNA base, we call that a polymorphism. Now, it doesn't necessarily mean it's a bad thing. It could mean that it's a substitution. It could mean that it's an increase in activity. It could be a deletion. It could be a decrease in activity. And in the case of the MTHFR gene, it is a decrease in enzyme activity that it affects. Now, just to recap, and I'm sure most of the listeners would understand, but let's just look at the folates, because as you quite rightly said, folate, it means it could mean one of three things. And I think, unfortunately, from a research perspective, researchers have until now always said folate when they mean folic acid. So folic acid is the synthetic form. It's man-made, and it cannot be used by the body unless the dihydrofolate reductase gene or enzyme is working to metabolize it. All forms of folate have to be converted eventually to methylfolate. Folinic acid, it is metabolically active, but it is not the biologically active form of folate. It still has to be converted to methylfolate to be used. So our main form of folate that we have in circulation that is biologically active, that makes SAMe for DNA methylation and our detox pathways and our estrogen metabolism and our neurotransmitters, is 5-methyl tetrahydrofolate. Right? That's really important to remember. And I think many practitioners in Australia think that folinic is just as good as methyl. And I think also many practitioners are afraid to use methyl because people react. And so they say, well, okay, you've reacted to methyl, let's take it out and use folinic instead. However, that is not the strategy. If someone is reacting to methylfolate, it essentially means that the uptake is blocked for a reason, and you as a practitioner have to find out why. Does that make sense?
Yeah, this is what Ben Lynch spoke about. I remember at the MTHFR Summit. What was that, 3 years ago? 2 years ago?
Yeah, 3 years ago, yeah.
God, the grey hairs. But what really impressed me about his talk was that he kept on saying, stop looking at the thing that you think you're looking at as being the be-all and end-all of the treatment paradigm. He said, look upstream, look what it affects, look what affects it. Really impressed me, actually, about Ben Lynch.
And I actually drew this diagram, and for those of you that can't see it, I'll explain it. And it's very simple. You see, folic acid has to use the DHFR enzyme to make tetrahydrofolate. So tetrahydrofolate is our precursor, let's say, to the other forms of folate that eventually become methylfolate. If someone is taking, and the research says this DHFR enzyme gets inhibited or slowed with 200 to 300 micrograms of folic acid a day. So let's say you have a polymorphism in DHFR and you're heterozygous to DHFR, so it's already downregulated. You then stick folic acid on top and it's going to downregulate it more. So what happens? You are actually not making methylfolate. And the research says that too much unmetabolized folic acid actually acts like an MTHFR deficiency and shuts down your ability to make methylfolate.
Has anybody delved into the actual biological plausible mechanism behind, like the functionality of that? Why would unmetabolized folic acid have that action in nature?
Because if an enzyme is slowed, it's slowed for a reason.
Yeah.
Because it senses that upstream something's too high. Right. And so I think most of these biochemical pathways, when you look at it, there's a very strong feedback mechanism going on. So if they sense something is high, it'll shut it down. But when you're looking at folic acid, it overwhelms the capacity of DHFR because that enzyme was never meant to, and I think when we looked at the original fortification of foods with folic acid, if it was only 140 micrograms that we were meant to be getting, hey, that's great. DHFR copes with that really well. There's no problem. But once you start to get in the realm of, let's say someone is getting up in the morning and they're having breakfast cereal fortified with folic acid. They then have a sandwich for lunch fortified with folic acid. They then have some pasta or some bickies or something like that fortified with folic acid. And then they're taking a multivitamin on top of that with 400 to 500 micrograms. And it's quite alarming in the US now. You're seeing supplements with 1,800 micrograms of folic acid. And you think, whoa, what are the researchers guesstimating that people are getting? And it's about 1,000. So irrespective of MTHFR polymorphisms, the general public can be affecting their folate status if that level of folic acid decreases the capacity of DHFR, because you cannot and will not make tetrahydrofolate.
Right. I know this is a segue, forgive my tangential mind, but on this diagram here, I'm just seeing once you have tetrahydrofolate and that gets metabolized into 10-formal tetrahydrofolate, that's involved in purine metabolism.
Yeah.
If somebody is on 5-MTHF, I know that it gets recycled back up. I get it.
Yeah.
But can that benefit, or does it have any beneficial effect on purine metabolism disorders, like, for instance, gout and even cardiovascular disease?
Well, we definitely know it helps cardiovascular disease. And I do think when you look at elevation in uric acid, I think there's an element of methylation deficiency, because that uric acid is downstream of your 1-carbon metabolism pathway.
Right.
But when I think what's really important is that if we know from the get-go that all folate has to be converted to 5-methyl, and we can say, okay, if you're having too much folic acid, or you've got polymorphisms that affect folinic acid, or polymorphisms that affect methylfolate, why wouldn't you use methylfolate to jump over it, give the body what it needs, and then take the pressure off DHFR and get the folic acid out of the system?
So, like, what I'm picking up is this unmetabolized folic acid is far more far-reaching than what we previously thought. Like, if you're dampening the action of the active component that you want in the body, it's almost like a blocking. Forgive my analogy, but it's kind of like an antihistamine blocking the receptor. Yeah,
it is. And I think this is my next area of research to look at unmetabolized folic acid. And it's really funny when you start publishing papers, and I've just had my first one on MTHFR published in the Journal of Integrative Medicine. And researchers come out of the woodwork and say, hey, this is my area of interest too. And I was very fortunate to get in contact with a very famous researcher, Stephen Bailey in the US, who's probably spent his whole career looking at unmetabolized folic acid. And he and a group of probably 13 other scientists around the world are very, very, very concerned about the levels of unmetabolized folic acid generally.
Right.
And this will blow your mind, but he sent me an email the other day to say he has a paper that shows that unmetabolized folic acid is a photosensitizer, i.e., if it's in your system, you're more likely to get burnt by the sun. And I thought, oh my goodness, this is really interesting. So methylfolate is not. Unmetabolized folic acid is a photosensitizer. So we are more likely to get damaged by the sun. We're a folic acid fortified country, and we have high incidence of melanoma. And I thought, oh, okay, so this probably has implications, as I said at the beginning, in many areas of our biochemistry.
So has anybody looked at its, sort of combination research, if you like, or the linkage research between folic acid or folates and vitamin D metabolism? Like, we know that people who gather sun exposure, because there is that issue of the alpha and the beta waves with regards to skin damage and melanoma, but those people that have higher levels of vitamin D post initial melanoma have a less chance of repeat melanoma diagnosis.
Yeah, because vitamin D is so critically important in A, skin, B, immune system, and it's a signaling molecule that has a major impact on gene expression.
Yeah.
So anyway, we digress. We're going to be here for the next 5 hours if we don't
3 hours
move on.
later. I tell you what, Carolyn, this is already such an in-depth topic. There is going to be other issues branching off of this. Would you mind coming back for another podcast and we'll discuss some of these issues that we've touched on?
Sure.
Would that be okay?
Yeah. You make a note of the issues and then we can explore those. We have to be focused
10
here.
podcasts later, we'll understand it. Yeah.
So I think the key point is that food-based folate, as in leafy green veggies, they do not have to go through DHFR. They're not like folic acid. They're a monoglutamate, which then the brush border enzyme directly convert to dihydrofolate and tetrahydrofolate. So remember that. Food-based folate does not go through DHFR. Folic acid does.
Right.
So when we look at polymorphisms in MTHFR, although there's about 30 of them, we only look at really 2 because that's where the majority of the research lies. And they're the C677T and the A1298C. And essentially all those numbers mean is chromosome 1, a cytosine is changed at 0.677 for a thymine, right? So it's a substitution and that causes a downregulation. Now, if someone is homozygous, it means that both mum and dad gave them the mutation. And that can be a 60 to 70% downregulation in their ability to make methylfolate. If they've got one copy, we call it heterozygous, and that can be a 30 to 40% downregulation. Now, you'll see that, from a fertility standpoint, generally the medical practice, the medical fraternity will say it's really only homozygous C677T that is the issue. But I think what this research highlights is that that's not necessarily the case. So if any of the prackies out there or the specialists are looking at A1298C, the CC or the homozygous, that's still a 50% downregulation and therefore is affecting our ability to make methylfolate. And if they have one of each, so a heterozygous C677T and a heterozygous A1298C, they've still got a 40 to 50% downregulation. And that's the crux of it. If you can't make your methylfolate, then DNA methylation and all those then things that follow on from that will be affected. And as I said, estrogen metabolism is one of them.
It's really interesting how medically a 30 to 40% downregulation of something that can affect so many issues would be trivialized, would be considered just a non-issue. I mean, that's 30 to 40% is massive.
It is. And I used to get really upset about it, but now I just know and understand it's a lack of education. And it's a lack of education because you've got the likes of the AMA saying it doesn't matter. And so what are the doctors don't have time to research like I do, or you would, or even most naturopaths would, or nutritionists. They don't have the time. And so at the end of the day, they've got to believe what they're being told. And if the AMA or the RACGP are saying it doesn't matter, then their general philosophy is it doesn't matter. They're also being told that the only connection you need to worry about is a homozygous MTHFR and an elevation in homocysteine. But let me tell you, most of the women we're seeing don't have high homocysteine, they got low. So that doesn't really make any sense because they're still infertile.
Yeah.
So if we go on to have a look, our research question was, do practitioners who test for MTHFR genetic polymorphisms in infertility patients use different forms and dosages of dietary and supplemental folate? Now, I think it's important to just highlight at this point that the practitioners we recruited for this study were members of our database,
Right.
which means that they are more aware, A, of MTHFR polymorphisms, B, they're more aware that it is going to have an impact in infertility patients. Can we assume that this is what all practitioners do? No, we can't. So we've just got to, upfront say that it was our database that we recruited from, because it was a prerequisite that you had to have an MTHFR polymorphism to be included in this study. Okay, so our aim was really to explore the pregnancy outcomes and actually see, well, okay, if we change or increase the dose of folate, what actually happens at the end of the process? How many of the patients were, what were the MTHFR polymorphisms, and what sort of dosage ranges were the practitioners using? And so if we look at the results, we broke down the results in terms of 5 key categories. What was the MTHFR polymorphism? What did the practitioners tell their patient in terms of folic acid in food? What did they tell their patients in terms of folate generally? What form should they take? What dose should they take? And then what was the pregnancy outcome of them doing that? So we had 12 cases, and you can see from the graph here, that the graphic, that we had one case in that 26 to 30 years. We had 5 that were 31 to 35 years. We had 3, 36 to 40, 2, 41 to 45, and 1 in that 46 plus.
That stands out, that one, 46 plus years.
And she'd had 10 failed IVF.
Wow.
Coming into this. And you can see from the miscarriage, they had gone from 1 miscarriage to 2 to 5 to 3. So most of them had had previous miscarriage. And I want to say that all 12 had been diagnosed with infertility by a fertility specialist. So this wasn't us diagnosing them with infertility. They were medically diagnosed as infertility. Right. So that's really important to remember that. And, with a background of some of these pregnancies, you think, oh my goodness, that's a lot for them to have gone through. So as a prerequisite, every single one of them had an MTHFR polymorphism. 1, which was surprising, only 1 was homozygous for C677T. But guess what? 5 were heterozygous for C677T. So where, people say it doesn't matter, 5 of these infertile patients had a heterozygous SNP. We didn't have any for the A1298C that were homozygous, but we had 2 heterozygous. And interestingly, 4 were compound heterozygous, so they had 1 of each polymorphism.
Carolyn, can I interrupt you? Given even the medical importance of folic acid, I'm doing quotation marks in the air here, are patients who present with multiple failures, fertility failure, are they investigated by orthodox medicine, infertility clinics, etc., for polymorphisms?
Only when they've had about 5 or 6 miscarriages.
Right.
Usually, generally after they've had 5 or 6 miscarriages, they'll go, oh, by the way, you may have MTHFR. And what is the standard protocol for those individuals? 5 milligrams of folic acid.
Right. 5 milligrams? That's not even prenatal.
5
forgive me. Sorry.
5,000 micrograms of folic acid is the standard treatment protocol for fertility specialists that highlight an MTHFR polymorphism. That's a problem. So half the patients were taking folate at their first appointment. And exactly as we just said, 2 of them were taking the high dose folic acid at 5,000 micrograms a day or higher. So what the prackies pretty well all said was, you know what, we want you to get rid of folic acid in your food, number one. So 75% of their 12 cases were told, get rid of it out of your diet, or at least be mindful of it. Folic acid was removed by all practitioners in supplemental form. So from the first initial appointment, not 1 microgram of folic acid was given to any patient. And every single one was prescribed methylfolate or a combination of folinic and methyl. We, as I said at the very beginning, when you asked me that question, we're only allowed 500 micrograms in a prenatal multivitamin. But the mean maximum dose per day for all 12 cases was 2,325 micrograms of methylfolate that they were given. All right? So that's way, way above 500 micrograms. Folinic, not all of them were given. Only 5 patients were given a combination, and the average was 670 micrograms a day. 3 of the patients presented with previous failed IVF. 2 of those were on the 5,000 micrograms of folic acid. They were all prescribed 5-methyl, told to avoid dietary folic acid, and all 3 successfully fell pregnant with IVF. So IVF, and I think this is a really important note, IVF is not going to help you if you have a folate problem. You can try IVF until you're blue in the face, but unless you know that your folate is optimal, it's still going to fail. So if IVF is the way to go, you still need to go through your process of preparing your patient for that IVF. And it still entails using good doses of folate. So I'm going to have to talk this graph because it's a really good one to show. Now, let's look at the heterozygous C677T and the doses that the prackies were giving to achieve pregnancy. So 3,500, 3,800. This one miscarried twice, but she was on the lowest dose of folate from anyone. 1,600, 2,500. So they're way, way higher doses. And in the case of our homozygous C677T, she was on 3,500. So really much, much higher doses than we expect. And then if we actually look at the outcome, as I said, there were 11 of 12 fell pregnant. 10 successfully had a live birth, even though they were all diagnosed with infertility. The one that miscarried twice, but she was on the lowest dose of folate. And the 12th lady had never fallen pregnant before or during or since. So we have to think there's obviously something outside this, and we obviously don't know her partner's MTHFR polymorphism. So it could have been many factors that affected that. So the overall result, which was really astounding, is that of 12 infertile women, when we took them off folic acid, we gave them much higher doses of methylfolate, 10 successfully had a baby, which is pretty good odds when you think about. And so what this final chart shows is that everybody had a baby except two. And one, unfortunately, I just don't think was on enough methylfolate. And the other one, as I said, we're not quite sure what was going on outside that. But you can see when you've got, 3 failed IVF and 1 miscarriage for one lady, 5 miscarriages for another, 2 miscarriages, 3 failed IUI, 5 failed IVF, failed ICSI, 2 miscarriages. I mean, these are pretty significant things that these women have been through, and yet they don't have only the 3 IVF ladies went back into IVF. Everybody else fell pregnant naturally.
Carolyn, with the couple of things, forgive me, that are whizzing around my head. So firstly, looking at the dosage required to achieve pregnancy, would it be a danger, or would it be open to conjecture that a higher dose of folate is required to achieve pregnancy, whereas folic acid is given in lower dosages? And I guess where I'm going there is, like, I can still remember one case many years ago when we didn't have the choice in Australia about folates. And that was a friend who had an exceedingly high homocysteine, and we tried to get it down, and I had to use 15 milligrams of the of folic acid. So that's 3 times the 5 milligrams of the S3 pharmacist only one. And even then we got it down to, I think it was 13 or 11. His homocysteine, and the thing that was the lock in the key in the lock was betaine.
Yes, because betaine's helping you recycle homocysteine, but the only elimination route is through the CBS pathway with the help of B6.
Right. So B6 is something I didn't entertain back then with regards.
So if you'd given trimethylglycine and B6, you would have got it down really quickly.
Right.
And I think had you given, say, let's say 200 micrograms of folic acid at the time with the betaine and the B6 and B12, you probably would have got it down.
Yeah, I can still remember a dose ranging study though, saying that adding B12 at higher and higher dosages only gave a minimal difference. But I granted this was using folic acid. Had they been given the methyl active, then they would have gotten appreciable reductions at lower dosages.
And we've got to be checking that homocysteine, because it is definitely, particularly in pregnancy, there's sort of all sorts of side issues that come from that, preeclampsia, blood pressure, different blood pressure implications, cardiovascular risk. All of those sort of things can affect homocysteine. But I think an elevation in homocysteine or a low homocysteine is telling us there is a deficiency in methionine synthase pathway. And because that's creating SAMe, we have a problem.
There's podcast number 3.
Yes. So homocysteine is incredibly important. We have got to have it at a good level. We can't have it high and we can't have it low. And a lot of these kids that are on very high pyrrole packs have homocysteine levels of 2 and 3. That's bad for their methylation. That's bad for their detox. It's bad generally for their mood. So you can't be bottoming out homocysteine either.
Well, I've even got issues about, if you suppress methylation of, let's say, the P53 on a of a cancer gene, are you setting a microenvironment up for them to get cancer way down the track, 20, 30 years down the track? Because there is that forgive my dim memory here, but I remember hearing South American research. Was it Chile? Was it Argentina? Where there was food fortification folic acid, and they saw a rise of colon cancer.
Yes.
Not that it affect the government stance on food fortification, didn't, but it was really interesting about a rise. Now, there could be so many confounders there. I get it.
Well, guess what? South America have the highest percentage of, other than outside the Mediterranean, of MTHFR homozygous polymorphisms.
Right. So here's where I'm going with this. Is there any research to date showing that folic acid supplementation dampens 5-MTHFR?
Yes.
Yeah?
Yes. So the one of the research studies that I put in my thesis, and in fact, let's go to that chart because it's probably Smith and Kim et al., 2008.
Yep.
They said that, there's over 3,500 studies on unmetabolized folic acid.
Whoa.
No one can seem to say, look, there's a definitive issue here. But the problem is that 96% of breastfeeding women have unmetabolized folic acid in their system, and they believe it reduces 5-methyl due to a potential downregulation of the folate binding protein. Smith and Kim et al. Go on to say that increase in unmetabolized folic acid acts as a folate antagonist, so it's shutting down MTHFR. It's almost a pseudo MTHFR deficiency. And so it's also linked with natural killer cell cytotoxicity in postmenopausal women, a particular study. Cobalamin deficiency, it's been linked with breast cancer, it's been linked with prostate cancer, it's been linked with autism. And so at some point, we have to be able to turn around and say, well, look, enough researching, we've got enough evidence to say, hey, this is a potential problem and we've got to look at it.
Can I also ask, my previous advice to pregnant women was never, ever take folic acid alone. And you've certainly alluded to that in one of the studies about, I'm going to say co-more, but it's not. Alongside folic acid. Cofactor, yeah, that there was a cobalamin deficiency.
Yeah.
How important would be just B12, and which B12 would you prefer? And is that another podcast?
Yeah, we could do I could talk for 3 hours on B12 because it's probably one of my absolute favorite things to talk about, because without B12, you cannot utilize methylfolate. End of story, full stop, that's it. And so understanding practitioners that really understand, B12 polymorphisms, I think will be the ones going forward that can really seriously affect chronic disease, fertility, because there are so many people with TCN2 polymorphisms which act like the train to get B12 from the blood to the cell. And if you have that polymorphism, it doesn't really matter what you do, unless you fix the B12 issue, you will never, ever get the person better.
Gotcha. Have you got any more slides to show us, Carolyn?
Let me just see. Okay. Yeah, this is probably good. 5-methyl. So what does the research actually tell us?
Right.
It tells us that 5-methyl may support folate status more quickly in pregnancy and preconception. So we've always heard all the research that, folic acid does just as good, is way better than methylfolate. And that's because there's been limited studies. But there's a lot more studies now coming out to say, hey, no, that's not necessarily the case. 5-methyl, will prevent neural tube defects. It increases folate status more quickly. It bypasses an MTHFR polymorphism. It's the main folate in the cord blood, so it's allowing the folate to be transported to the fetus. It's the main form that crosses the blood-brain barrier. It increases mean plasma and red cell folate concentration significantly. And that was a really good test, that particular study. And it said, look, all right, and we have this all the time. Someone rings you up and says, I'm pregnant. By the way, I'm homozygous MTHFR and I haven't been taking any folate. And you think, oh my goodness, okay, what do? Well, that study said you give 7.5 milligrams, so that's 7,500 micrograms, 2 or 3 times a day for 4 days. You've got folate status up to improve that pregnancy, to ensure viability.
But
that's pretty amazing.
Okay, but obviously that's got to be rescued very early.
It's got to be rescued very early.
Yeah.
But with folic acid, you could never do that. It would take you 21 to 28 days to get an acceptable level of folate.
Oh, forgive me. So what was the time to raising the blood? 3
to 4 days.
Right. Okay.
So I recently had a call from a fertility specialist that I work with and said, I need your help. I've got this patient, exactly that scenario. And I said, okay, how many weeks is she? She's only just found out. So she's 4 weeks max. Okay, what's her background? Oh, she's had 3 miscarriages before. When were the miscarriages? 6 to 8 weeks. I thought, right. So I gave her 5 milligrams 3 times a day of methylfolate with B12 and all the other bits and pieces that I would give her. And she's now still pregnant at 15 weeks. So we saved, I think we really did save that pregnancy.
There's a really interesting issue there about, you said max 4 weeks, but there's many people that don't find out till, 8 weeks odd.
Oh, yeah, of course. But by day 21, the neural tubes close. So
that's right.
You just have to hope. Well, sometimes I say, well, if you have a miscarriage, it's probably better because you haven't been taking your folate.
That's exactly right. I see, I remember on the graph there was a case of trisomy, and there is I remember a very old paper, or it was a review of a paper by Dr. Bob Buist, who is formative in my learning. Thank you so much, Bob. And what he was speaking about was teratosthesia, i.e. folate metabolism in adequate amounts actually helped your body to get rid of damaged DNA, fetal DNA. And so, forgive me, I shouldn't say fetal DNA, damaged fetuses. It caused spontaneous miscarriages for those fetuses that would have never been carried to term, or which, if carried to term, might well have had a deformity. It was a really interesting concept, very, very hard for the woman especially to come to terms with, because they put so much love and energy into their hope of having a baby. And indeed this, Lee and I, my wife and I, discussed this with 2 miscarriages, but to me, it's a very interesting concept about the eloquent protective mechanisms of nature to further, if it can, the perfect baby. It's a hard call, I get it, but
well, she had been taking, to be fair, she'd been taking 500 micrograms of folate, but she had been taking the leading prenatal with not folic acid, with not folate in it. And so I just upped the level really quickly to get her over that probably next 2 to 3 weeks. And I think, this is part of the problem that we have with some of the protocols for autoimmunity, where they're giving, prednisone and other things. You are potentially prolonging an unviable fetus that, you shouldn't be doing. And that's one of the reasons that I will always say to all these women that have done egg collection previously, why would you use crappy eggs? Like, seriously, we don't want you to use them. Get rid of them. But they're so attached to the fact that they've done an egg collection. So I say, all right, don't worry about those. Leave them sitting there, but let's use the new good eggs and the new good sperm, and let's give that a go. And 90% of the time it will work. Yeah,
such a hard issue though, because there's so much emotion invested. I mean, women that I've known of going through IVF, it's almost like they have PTS. I'm going to say injury, PTSI, not PTSD, but they are damaged emotionally, and they need really deep counselling to get over that, with the emotion of, or that they've invested in long-term IVF. It's heartbreaking for them.
Well, I guess this is what really drives me every day of my life. If we can be saying to women, you need to be taking the right form of folate, number one. Number two, you need to be taking the right dose. And number three, you need to be checking right from word go, do you have an MTHFR polymorphism? If you said that to 18-year-olds saying, look, I know you're not ready for fertility yet, and I know you're not thinking about babies, but hey, just make sure that you're taking the right form of folate. Don't take a multivitamin with folic acid in it. Take methylfolate. And if we could actually get people thinking about it early on, we could stop 90% of all the bloody miscarriages out there. And that's a big statement, I know, but I see it.
I tell you, I remember being quite reticent about testing SNPs. And now that I've read the medical information with regards to certain SNPs and medication requirements, let's say triple therapy for Helicobacter pylori, and the doubling of the dose, the doubling of the need of the dose for esomeprazole in certain gene SNPs. So I yearn for the day that we have the artificial intelligence to be able to look at not just one SNP, but a group of SNPs, and then say, okay, how does this affect disease presence or modification?
But that's what we do now, Andrew, in our practitioner training.
We don't have the artificial intelligence, we've just got the intelligence.
That's right, exactly. And I think the classic example that you just used is so important, because how good would it be if GPs understood, so they're the first line of defense when it comes to most, 90% of the population, if they could say, all right, you're depressed, let's have a look at your MAO-A and your COMT. And okay, you are homozygous MAO-A, you've got a slow MAO-A, I'm not going to give you serotonin reuptake inhibitor. No, I'm not going to do that because it's not going to work. But I can see that your COMT is fast, you need dopamine support. I have recently had a horrible case where a very young patient of mine was put on an SSRI. She got worse. She got suicidal. She was on literally 24-hour watch by her parents. I wrote a letter to her psychiatrist saying she has MAO-A inhibition and shouldn't be on an SSRI that has, MAO activity. She should be on something else, bypass MAO, but get rid of it. And they refused to do it. This poor girl for 9 months was literally tied to her mother's arm because they were so scared to leave her for 1 second. They eventually changed it, and within 4 weeks, she's back at school.
That's a real controversial subject, that one. Of
course it is, but you need to understand your genetic susceptibility, not only for drugs, but also for, how do you support neurotransmitters? If someone has a really low or fast COMT activity and their dopamine is depleted every day, they're the more addictive personalities. They're the ones that are going to be seeking the drugs and the smoking and the alcohol and the fast cars and the, crazy athletics and everything else, and more prone to depression. But you can change that in a matter of weeks.
The thing that I'm getting at is that doctors are beholden to the guidelines that are approved for them. Having said that, it's not uncommon for doctors to use drugs off license. So, what I'd love to see is something like a group of infertility specialists who used to do their therapy one way with folic acid and did a practice audit of their outcomes, their patient outcomes, and then post, let me say, enlightening, to the issue of polymorphisms and how they can affect patients, they did another practice audit. And it would be really interesting just to see the differences. And as you say earlier, we'd have to let the research leaders. Carolyn, there's so much more to cover. There really is. Can I just ask, because we haven't got all day, unfortunately. I could talk for hours, but there's so much that I'm learning. Is there more that we can learn? Do you have any other resources that practitioners can learn from?
Yes. So I have a couple of practitioner training programs. One is an online portal where they can start to learn some of this genetic susceptibility themselves. We've got 3 levels, a beginners, an intermediate, and a advanced. We also do deep dives every month into certain topics. So one of the deep dives we've done, for example, is homocysteine. How do you know what the good level is? If it's too low, how do you bring it up? If it's too high, how do you bring it down? We look into copper, we look into zinc, and that's sort of like a self-learning. We have Facebook groups attached to that. But then we have our dedicated mastermind program, which is an 8-week intensive that teaches prackies how to include this genetic susceptibility observations into clinical practice. So if you've got the susceptibility, what that might potentially mean, and then what environmental influences triggers that susceptibility to make it worse. And so I think part of the problem that a lot of prackies are getting into at the moment is they've got the biochemistry, they know the theory, but what's really hard is the clinical application. But what does that mean? I've got all this stuff and I don't know how to decipher it and start with a treatment plan. And so that's what we really focus on in the mastermind. And invariably, every practitioner that's gone through it, their overriding comment at the end has been, it's given me the confidence to know where to start. I feel like I've got so many tools now in my toolkit, and I'm quite excited in how I can then achieve the outcomes, the health outcomes I'm achieving. And one of the integrative GPs that did the course, he said to me, when you said this is going to be improving my practice and creating wait lists, he said, I thought you would, just saying that. But he said, I am so flippin' busy, I just don't know how to keep up with the patient load. He said, I can't tell you how much this has helped my outcomes. He said, because I'm having so much success, everybody is now wanting to come to me. And he said, it's completely revolutionized. Yes, it has caused a problem, but it's a good problem. But part of the problem, and my philosophy is, I just went to the NHAA conference where I presented some of this research. And, there was a question there that someone said, look, I'm really upset by integrative doctors taking away from our space. And I thought to myself, we need 1 million integrative GPs and 1 million naturopaths and 1 million everybody else to be able to say, hey, I know how to deal with these chronic health conditions. We still couldn't treat everybody that we need to treat. And that's why I'm so passionate about teaching other prackies this stuff, because we've got 7 prackies in our practice now. We cannot keep up with the demand with 7 practitioners. So there's a demand, and I honestly believe that those practitioners who avoid the genetic susceptibility and don't look into it and at least understand it, they're going to be left behind, because the patient demand now is, I need to know if there's something that's making me feel this way. Can you help me decipher it? And I'd so much prefer the practitioners be really confident and really, to be able to say, all right, well, just because you have a polymorphism or a SNP doesn't mean there's necessarily a problem, but we're going to put all the things together and we're going to see if there is. And there's so many great tools now with the organic acids tests and how we put the genetics and the organic acids together. It's really powerful stuff.
I think this is the whole story, which of course is another podcast. But Carolyn, thank you so much for taking us through unmetabolized folic acid, the issues with infertility and indeed successful pregnancy, and of course the other things that we covered again today. I have to thank you also, our listeners, our viewers, for joining us today. So remember to catch up on all the other podcasts by Vicky, Ricky, and myself, Andrew Whitfield-Cook. And thanks for joining us today on The Health Chat.